This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, we have a 12-year-old girl who has presented to the hospital with an history of penetrating injury with a pen. A pen poked into her eye about 4 days back, and now she has this clinical condition. So what we can see is obviously the traumatic cataract, and we can see the lens matter all in the antechamber. The antechamber is very shallow, and the left hand side we can see the sealed corneal wound. The pressure is on 24, and the patient is on treatment with antibiotic and steroid eye drops along with IOP lowering medications. So whenever we have a situation where the anticapsule is breached and the lens matter is exposed, this is a condition which warrants immediate surgical intervention. So at this stage, let's list out what are the difficulties which we may encounter in the surgery. Point number 1, the anticapsule is torn, but we are unable to delineate the extent of the anticapsular tear. Has it extended up to the equator or not, we don't know, and we also don't know the exact location because what we're seeing is a homogeneous white mass. Number 2, we're unable to predict whether the posterior capsule is intact or not. Number 3, removing the lens matter is going to be difficult. It's not going to be difficult because in a young child, the lens matter is going to be very soft. We can just aspirate. Then number 4, is there any prolapse of vitreous at present? We don't know. The B-scan does show a normal posterior segment, and this is a situation. So in such an event where we are not sure about the integrity of the posterior capsule, it's better to be prepared with multiple options. Like we need to always be ready with other IOL options like a multi-piece lens or an iris supported lens or a scleral fixated lens. And of course, needless to say, our anterior vitrectomy unit has to be ready. The surgery is being done under the supervision of an anesthetist, although the patient is relatively cooperative, and I'm giving a posterior subtenance injection. The anesthetist has given a mild sedation for the patient, and we're good to go. So before I start the surgery, I would just want to pause here and ask all the younger surgeons to write down the notes, what are the steps which you're going to do and how we're going to plan the surgery in this patient. Okay, I assume that you've written down the steps of the surgery. So let me just share my plan. So first thing, I would like to go ahead and do the 2 side port incisions. And I would like to dilate the pupil by using BSS mixed with adrenaline injected into the intracamerally. Then I'm going to assess whether I can visualize the anterior capsule. If I'm not able to visualize, then I'm going to stain the capsule and then proceed. So to help the staining of the capsule, I'm going to avoid the use of viscoelastic in the beginning itself. So let's see how things turn out. The 2 side ports are done. So I'm using BSS with adrenaline just to see whether the pupil dilates, and the pupil does dilate well. And thankfully I'm able to delineate the extent of the anterocapsular tear. It's a vertical tear which is extending all the way up to the equator on either sides. So because the visualization is relatively clear, I'm not going to go ahead and stain the capsule. I'm directly going in with my bimanual irrigation aspiration. The left hand has the irrigation and the right hand has the aspiration. And I begin aspirating the soft lens matter. As we discussed previously, since the patient is a young child, the lens matter would be very soft and can easily be aspirated with the aspiration cannula itself. Slowly but surely, the lens matter is stripped off and then aspirated. So as there is a hint of a red glow, I'm trying to find out whether there is any posterior capsular tear. There doesn't seem to be any. And as we can see, the other clue is that as I'm trying to aspirate, the cortex is coming quite easily and fast. So again, indication that there is no vitreous prolapse. The most important step here is not to allow any chamber shallowing. So before the irrigation comes out, I'm going to form the chamber with OVD, then the irrigation comes out and the hands are switched. The cortex from the other quadrant is aspirated. And lo and behold, in a couple of minutes, the case is almost complete. So we can clearly see the extent of the anterocapsular tear, and thankfully for the child, there is not a posterior capsular tear. So again, before I come out, I'm going to inject OVD into the eye and come out. So now we have to implant the intraocular lens. Because I'm sure that the lens can go into the bag, I'm going to use a single piece hydrophobic acrylic lens. The bag is filled with a cohesive OVD. At this point, I'm going to create the main incision. So mind you, until now, we have managed the case only with two 1mm side port incisions. The single piece lens is gently introduced into the antechamber, and as it unfolds, the haptics are then being maneuvered into the capsular bag in the appropriate direction. We want the haptics to be 90 degrees away from the meridian of the capsular tear. So now, gently but surely, both the haptics are sitting in the right place. Now is the time to remove the OVD. There's a small capsular tag which is hovering around, but I wouldn't want to tear it now, because in doing so, the anterocapsule tear can become a little bit bigger than what I would have liked. In the pediatric patients, the most important prerequisite is to have the lens in the bag, and this much of a capsular opening is fine. It's unlikely to close or phimose, so I'm not going to enlarge the capsular opening. The OVD both in front and behind the lens is aspirated out, and we can see a small dot here. This is a Mittendorf dot, and nothing to bother about it. That's it, the case is done. All the ports are hydrated, and these are the first day post-op pictures. And this is the 4th day post-op picture, and even after dilatation we can see that the lens is very well centered and the patient is having an excellent visual outcome. So to summarize, some traumatic cataracts can be surprisingly very easily. This was one case where it was really just make 2 paracentesis incisions and aspirate all the soft cataract, and that's it, the case was done. And thankfully for the patient, the posterior capsule was intact and the penetrating injury in the cornea was also away from the visual axis, so it did not have any impact on the final visual outcome as well. So these instances are relatively rare, where we have such a clean cut trauma only to the lens, and everything else is fine. And invariably these patients do well. But nevertheless, the message is, whenever we're dealing with a traumatic cataract, it's better to be prepared for the worst possible things. And then if things go on very well, it would be a very pleasant surprise. So preparation is the key. So that was it. Thank you for watching and hope you found this helpful.